Hello, my name is Susie Stever, and I'm the pharmacist lead with the Northern Health Palliative Care Team. Thank you for joining me for this webinar on the Fentanyl Transdermal Patch Order Set. This is a new order set that was put in place in Northern Health in October 2019. I have nothing to disclose. The objectives I hope to cover today are to understand why Northern Health has a fentanyl transdermal patch order set, to know how to utilize the patch order set, to understand when using a patch is indicated and conversely when it may not be the best option, be comfortable rotating to a fentanyl transdermal patch from another opiate, and to understand how to safely and effectively titrate the patch dose. Looking at why we considered putting in this order set. So as of October 2019, there were 636 PSL reports in Northern Health involving the fentanyl transdermal patch. 82 of these were coded as a level 2, which means that there was minor harm, and 21 were coded as a level 3, which is a moderate degree of harm to patients. The Institute for Safe Medical Practices lists the fentanyl transdermal patch as a high alert medication, which is defined as those bearing a heightened risk of causing significant patient harm when used in error. Due to this designation, it also shows how important it is that we do use the fentanyl transdermal patch appropriately in our patient population. ISMP went further to make recommendations on the safe use of the fentanyl transdermal patch, and these following recommendations include to create specific prescribing and dispensing guidelines. So those should be congruent with the product labeling and referenced during the order entry of the medication, both in the inpatient and the outpatient setting. So they recommend that it could include an equianalgesic conversion table to help prescribers convert patients to an appropriate fentanyl patch based on pre-existing opiate doses that the patient has been taking. They also recommend to determine the indication. So pharmacists can be involved in this step, and it's important to determine the indication and ensure the patient is opiate tolerant and suffering from chronic stable pain before they dispense this medication. They recommend to set dosing limits. So this involves computer order entry systems and flagging. So ideally, having a computer order entry system that would flash an alert on the screen or create a hard stop if more than a certain strength of patch is prescribed as a first dose. They also recommend that for patients admitted to hospital, and if they've been using a fentanyl transdermal patch at home, that the dose is verified during MedRec and that the verified drug list is sent to the pharmacy. So number 4, they recommend to assess concomitant use of other opiates, and this is to reduce the risk of an overdose. So we really want to make sure we take into consideration any other opiates that have been prescribed for this patient when we're evaluating the appropriateness of the patient's fentanyl patch dose. They recommend limiting prescribing privileges. So an inpatient setting, they suggested to consider limiting the prescribing of the patch to certain categories of prescribers who've been educated about the drug and maybe have some sort of privilege put in place. Number 6, the mandatory patient education, and that's for not only the patient but also if there's any caregivers of the patient to understand what the fentanyl transdermal patch is for, how it works, the proper disposal, and the proper storage of it, and to know the signs of an overdose. So not only healthcare practitioners that are prescribing the patch, but also nurses, patients, caregivers who are placing the patch on the skin should all be aware of the signs of and symptoms of a fentanyl overdose. So when we developed the fentanyl order set, we were hoping that we could include as many of these recommendations as possible in the order set to help with the safe prescribing of the fentanyl transdermal patch. This is an example of the fentanyl transdermal patch order set. It is very busy, and I don't expect that you would be able to read through it from here, but I would recommend that you print off a copy from Document Source and have a look at it just to become familiar with the resources that are available, as well as the steps for ordering the patch that are recommended. So that would include ensuring that the two criteria are met for ordering the patch, that the patient has chronic stable pain, and that they have demonstrated opiate tolerance. And as well, thinking about the indication, is this a new start, continuing a dose, increasing a dose, or decreasing a dose? And then including the dose of the patch as well as the dose for the breakthrough opiate that would be provided as well. So we're going to just have a quick fentanyl patch refresher, which I'm sure you're familiar with, but it's always kind of nice to have a little bit of a refresher. So the fentanyl transdermal patch is quite potent. It's 80 to 100 times more potent than morphine, and it's really well suited for transdermal delivery because it has high lipophilic properties, and is low molecular weight and has a high potency. So we can get quite a lot of strength to our opiate in a very small volume. This also means that it is suitable for sublingual use, and we will use it for instant pain for that as well. After administration or application of the patch, the blood concentrations level off between 12 and 24 hours. So it does take time to have the effects of the patch seen. And even though the concentration levels are stable, we don't really see the full clinical effects until closer to 24 to 48 hours after a single patch application. This is a good reason to see why the fentanyl transdermal patch may not be the best option for any acute or unstable pain, since to see the full effects would take so long that rather than actually treating the pain, you would be chasing the pain and never really getting a good handle on it, with it taking so long for the patch to take full effect. The steady state level is achieved after multiple patch dosings. So it may be by day 6, but for some individuals, it can take as long as up to 12 days. That's something to consider whenever we're looking at changing the dose of a patch, and escalating the dose based on the pain that a patient may be experiencing. So whenever the strength or patch dose is increased, we would want to wait at least 2 applications or 6 days before we'd have any further increase in the dose. With this continuous use of the patch, the concentrations continue to rise for a few systemic applications, so it does require that sequential 72-hour application, one after the other, for the patients to reach and maintain a steady state serum concentration. When we see orders for fentanyl patches that are increasing every 24 to 48 hours in their dose, that's not an appropriate use of it, and we're really not even seeing the full effects of the patch before we're increasing the dose again, and that can lead to toxicities and possible overdose. So we want to avoid that. Keep in mind that the amount of medication that's absorbed from the patch can be variable depending on the individual. So based on skin permeability, body clearance, the amount of fatty tissue that it can deposit in, this can all affect the way that the body is utilizing and absorbing the fentanyl transdermal patch. After the patch is removed, serum concentrations do decline gradually because we do have that reservoir in the fatty tissue. So even though the patch is removed, you can see the effects of the medication for long afterwards. So after 17 hours, there's only been a 50% decrease in the serum concentration of fentanyl in the body. And this again can range anywhere from 13 to 22 hours, depending on the individual and the absorption from the fat stores. With the patch, there's no ceiling dose, but the dose is limited by the available skin coverage because there's only certain areas where you would apply the patch, and there's only so much that the body can absorb. At some point, you won't be getting that linear effect of increasing the dose and the benefits of the medication. When you see doses around 300 microgram per hour, and if you find that you're still escalating the dose, that's a good time when you should really stop and assess whether or not this is still an appropriate medication for the patient, or if we should be looking at other means of analgesia or maybe some other opiate options because the patient maybe isn't getting the full benefit of this. There are no known active metabolites with fentanyl transdermal patch, which makes it a good option for patients that have kidney failure. So the indications for using the fentanyl transdermal patch. If a patient has poor absorption of oral opiates, if they have chronic stable pain, so chronic stable pain is defined as pain that has been stable and controlled for at least 48 hours. For patients that require around the clock opiate treatment, so regular dosing, not a patient that's only taking opiates PRN. For patients that have renal failure, and there is the potential that the fentanyl transdermal patch has a lower risk of causing constipation, nausea, and histamine release. So for patients that are struggling with this from other opiates, the fentanyl transdermal patch may be a good option. There's also a better compliance with the fentanyl transdermal patch because it is something that just needs to be applied every 72 hours versus other options that maybe they're taking every 4 or 6 hours, or even with the long acting every 12 hours. Some cautions or warnings to consider when prescribing the fentanyl transdermal patch. The patch may not be appropriate for patients with fever, diaphoresis, cachexia, morbid obesity, or ascites. These conditions may have a significant effect on the absorption, blood levels, and clinical effects of the drug. For cachectic patients, they may have reduced skin permeability and reduced subcutaneous fat tissue, so the drug depot transfer and pharmacokinetics may be altered. For patients that have advanced cancer, they may be suffering from sweating or cachexia, and they also may have reduced absorption of the fentanyl patch. For elderly or debilitated patients, again, due to poor fat stores, muscle wasting, or altered clearance, they can experience altered pharmacokinetics. If the titration is being done frequently, we want to switch to a short-acting preparation. If pain is rapidly escalating or pain is requiring frequent titrations, using a short-acting opiate every 4 hours until the pain is controlled is a better option than using the fentanyl transdermal patch. For patients that are only requiring an as-needed analgesic, this is not the best option as well. It is only for patients that have been requiring around-the-clock opiate analgesia. It's not for use in opiate-naive patients, and that's defined as individuals on opiates for less than 1 week at a dose of less than 60 milligrams per day of oral morphine or equivalent. And it's not for use in postoperative pain. We want to avoid using the patch in patients with significant respiratory depression and patients who have acute or severe bronchial asthma. We want to avoid the use in patients that may be experiencing exposure to direct external heat sources, such as heating pads, electric blankets, hot baths, or hot tubs. And this can increase, the heat can increase the absorption and may result in a fatal overdose. So with the fentanyl transdermal patch, we want to keep in mind possible drug interactions, and this is a good opportunity to utilize your pharmacist, especially if you have a patient who's on multiple medications and you're thinking of starting the fentanyl transdermal patch, or if you have a patient who's on multiple medications and you're not seeing the effects that you would expect from the fentanyl patch, and it could be due to an interaction with some of their other meds. So fentanyl is metabolized by cytochrome P453A4, and therefore, if you have any CYP3A4 inhibitors, you may find that you have increased levels of fentanyl. And if there's any CYP3A4 inducers, you can decrease the levels of fentanyl in the serum. So keep in mind how other medications could be affecting the fentanyl transdermal patch. And keep in mind, especially if you're thinking about what breakthrough dose you're going to be using with the fentanyl patch, if patients are on a medication that acts as an inducer, you may be needing higher doses of the fentanyl transdermal patch to have the same effect. However, when you're using the breakthrough medications of, say, morphine or hydromorphone, those are not affected by a CYP3A4 inducer, and you may need lower levels for an adequate breakthrough dose. And again, it's a good opportunity to utilize your pharmacist. Looking at storage and disposal of the fentanyl transdermal patch, this is very important for education with patients and caregivers. So we want to store any new and used patches out of sight, away from children and pets, or any others who could possibly misuse the patch. And that's because even when the patch is used, so after 72 hours it's removed from the patient, it can still contain 57 to 59% of the original fentanyl content. And especially with those higher patch doses, that can be quite a lot of fentanyl left over, and that can cause harm, especially if anybody is opiate naive and they inadvertently get a hold of it. Therefore, after the patch is removed, you want to instruct patients to fold the patch in half, sticky sides together, and dispose of it immediately, either in a tamper-proof container or in a child-resistant container. I have an example here of a sharps container which can be used, but also something maybe with a small entrance, such as a milk container, or you can also flush it down the toilet. Not very environmentally friendly, but it is a safe disposal. So we're going to now look at the order set and how we can utilize it and what resources are available. So when we're looking at applying the order set, especially for patients that are new to a fentanyl transdermal patch, there are resources available on that second page or the back side of the order set to help with converting from another opiate to a fentanyl transdermal patch. So to start with, you don't want to convert to a fentanyl patch if the patient was previously on codeine or tramadol. And the reason for this is when they were looking at the conversion, they found that the codeine and tramadol, there's a lot of interpatient variability in their metabolism and even the safety and effectiveness when converting over. So they couldn't give a direct conversion, and therefore there is no direct conversion and it isn't included on the table. We want to assess a patient's 24-hour opiate requirements of either morphine, hydromorphone, or oxycodone. And we're going to take that total dose to come up with our fentanyl transdermal patch. So this is the table that's found on the back of the order set, which gives us the equianalgesic conversion from an opiate to a fentanyl transdermal patch. This chart is unidirectional, so you only go from left to right. And this is because within this chart is built in the incomplete opiate cross tolerance when converting from one opiate to another. If you are going from either morphine, hydromorphone, or oxycodone, you would go across and look at the fentanyl transdermal patch dose, and that's the dose you'd go with. You don't need to do any further dose reductions. Normally, when we look at converting from one opiate to another, we expect there to be some incomplete cross tolerance. Therefore, you would normally further reduce the new opiate dose by anywhere from 25 to 50%. But because this is already built into the table, you don't need to do any further dose reductions. That is also why you can't use this chart in reverse. So if you were looking at going from the fentanyl transdermal patch back to hydromorphone, if you were to use this chart in reverse, you would actually be giving them a much higher dose of the oral hydromorphone, because not only would you be converting backwards and not have that 25% to 50% dose reduction included, but you're also looking at it being a higher dose because the dose reduction has already been built into the table. So this is a unidirectional chart and should only be used when converting from an opiate to the fentanyl transdermal patch. You'll also note that there is no 12 microgram patch indicated on this, and that is because it's not indicated as an initial fentanyl treatment dose. In order to use a fentanyl transdermal patch, a patient should be opiate tolerant, so they should be on a minimal dose of 60 milligrams per day of oral morphine or equivalent, and that would translate into a 25 microgram patch. The 12 microgram patch can be used when escalating or titrating the dose up for any in-between doses such as rather than going from 25 to 50, you could go from a 25 microgram patch to a 37 microgram patch. So continuing on, when converting from an opiate to the fentanyl transdermal patch, again, you don't need to dose reduce any further. Just use the dose that's indicated on the chart. And the second step would be to always provide a breakthrough dose. Once a patch is started, you want to monitor for any adverse effects during the initiation, but also any dose increases that can occur. This is a chart also found on the order set. So this gives you the approximate breakthrough doses recommended for the fentanyl transdermal patch. You look at the patch strength on the left, and then going across, you can see what the recommended dose is. And it's very important to keep in mind that the oral dose and the sub-Q dose for morphine and hydromorphone are not equivalent. And we're also looking at the switch schedule. So especially when a fentanyl transdermal patch is initiated, we want to look at transitioning a person off of their current opiate onto the fentanyl transdermal patch without having any pain crises or any loss of that pain control that that the patient has had. So depending on the route of the opiate that they've been on and the frequency, that'll dictate the rotation schedule. This table indicates the switch schedule for when you're discontinuing an opiate and transitioning onto the fentanyl transdermal patch. With this chart, it does indicate the times as 0, 4, 8, and 12 hours, but I would recommend that when ordering the fentanyl transdermal patch for the first time and stopping their old opiate, that you indicate specific times just for clear communication to the caregiver, for nursing, and for pharmacy, so that everybody understands when these medications should be given and when they should be stopped. So for example, if someone was on an immediate release medication and they were transitioning to the transdermal patch, if this was going to start at, say, 9 a.m., the order would say at 9 a.m., apply the fentanyl patch and give the regular immediate release dose. Then at 1300, give that regular immediate release dose. Then at 1700, give the last regular immediate release dose and stop. So you could still say, give this dose, then discontinue that medication, and there'd be no more regular doses. And it's strongly encouraged to use breakthrough doses during this transition period, just to make sure that if there is any change in pain management, or because this fentanyl patch dose is quite conservative, the patient may experience a more increased pain, and it's important to have those breakthrough doses available for covering that period of time when you're transitioning onto the patch. Looking at the patch application, things to keep in mind: avoid cuts or sores, utilize a flat surface where there's limited skin movement or limited clothing that could be rubbing against the patch and causing the patch to come off. There are patients that have difficulty with keeping the patch on, so when it's first applied, you want to hold the palm of the hand over the patch for 30 seconds, but you can also put a transparent film over it, such as Tegaderm or Biocclusive, just to make sure that the patch does stay on. And another option is taking like a fluticasone or a Flovent in MDI inhaler and spraying it on the area where you're going to apply the patch, and then apply the patch. When we're looking at adjusting the dose of the patch, after the initial application, you want to wait a minimum of 3 days before that first dose increase. And that goes along with how the fentanyl patch works, how it's absorbed, and how long it takes for the effectiveness and to reach steady state. For any subsequent dose increases, we want to wait a minimum of 6 days following the previous application. And that is, again, because it does take time to reach steady state again. And if you titrate the dose up too quickly, you're not getting the full benefit of the fentanyl before you're going up to the next dose. And again, that increases your risk of having a patient experience toxicity or having an overdose. When we're going to be changing the patch strength, so if someone is going to be increasing or decreasing, ideally we want to remove all of the patches that are on the body and then place all new patches on. And that just makes sure that the patches all have the same start date. It's less confusing then for those that are involved with the patch. We have had patients come to the hospital that have multiple patches placed with 2 or 3 different dates written on them, and that's because a dose was escalating, and instead of removing all the patches, they added more patches on, and that can be confusing to know that are all the patches accounted for? Was the dose increase what we expected, or was an extra one added because they didn't see that there was one tucked away? So that can be very unsafe. It's just better to remove all patches and then put all new patches on. And then again, we want to calculate the total amount of breakthrough doses in the 24 hours just prior to the dose change to help us guide how much we want to increase the patch by. Because if we base our dose increase on the first 24 hours, we were utilizing the breakthrough doses to help with the transition onto the fentanyl transdermal patch. And there's a good chance that, especially for the first 24 to 48 hours, the patient was needing more breakthrough doses. But it's really on that day 3 or even day 6 before you're thinking about increasing the dose again, where the patch has now reached steady state and you have a better idea of how many breakthrough doses were really required and can base the dose adjustment on that amount of breakthrough dose. In an overdose, you want to remove all the fentanyl patches. We want to physically or verbally stimulate the patient. I put naloxone question mark, and that's because when considering whether or not to use naloxone, you have to assess the results of reversing the symptom control of the opiate. So we need to consider the patient. Is this a patient that it has chronic pain? Is this a patient who is maybe new to using the fentanyl patch? Or is this maybe a palliative patient? So for palliative patients, we rarely, if ever, use naloxone. And if we were to use it, it would be at a very low dose, so 0.04 milligrams. Whereas if it's a patient who is maybe new to the fentanyl patch, that may be somebody where we would consider using naloxone, and then we would possibly consider using the usual dose of, say, 0.4 milligrams. So we didn't include naloxone on the order set because it really, the patient needs to be assessed and determined whether or not, in their case, we should use naloxone. If you were to use naloxone on a patient that had the fentanyl transdermal patch, keep in mind that naloxone effects wear off in anywhere from 30 minutes to 80 minutes. And as we saw earlier in the slides, the fentanyl transdermal patch effects are very gradual to wear off even once the patch is removed. So you're probably going to need continuous monitoring and multiple doses of naloxone before we really see the amount of medication leave the system that would require no more naloxone dosing. We want to make sure, again, if when we're removing all the patches, that we dispose of them safely. And keep in mind, if a patient is deceased, you also want to make sure you remove all of the patches. We want to monitor the respirate and level of consciousness of the patient, at least for the first 48 hours. So 24 hours, you want to monitor it closely, but even up to 48 hours, make sure that you're keeping an eye on the patient. And then I have listed there the drug elimination rate as a reminder. So now let's apply this to a case. So we're looking at AW. He's a 60-70-year-old male with urothelial carcinoma with mets to bone and lung. He's been experiencing pain in his lower back. He had a CT to his spine and pelvis, and that showed that he had mets to his lumbar and thoracic spine, pelvis, and lung. This was diagnosed 1 year ago, and AW underwent a radical cystectomy, bilateral pelvic lymph node dissection, he had radiation, and he had chemotherapy. But currently, he's not on any active treatments. He lives with his wife, independent at home, and he has no children. Currently, his medications are hydromorphone, sustained release 36 milligrams twice a day regularly, and he takes hydromorphone 8 milligrams orally every hour as needed for breakthrough pain. He's been using 1 to 2 breakthrough doses every 24 hours, and it's based on how much he's mobilizing or if he's had any exacerbation to his pain. He's also on metoclopramide as needed for nausea, Senna for his bowels, pantoprazole for acid reflux, and zopiclone to help him sleep at night. His labs are shown here, and everything is pretty much in the normal range. He has a slightly elevated ALP, and that could be due to his bony mets. So when we're looking at pain, we like to have the patient give us an idea based on a scale. So he describes his pain as a 2 out of 10 in his lower back, and it's dull and aching when he's sitting. When he's ambulating, this pain increases to 4 out of 10, and he has some sharp and aching pain. The pain wraps around his lower back and includes his right pelvic area, and then it also shoots down his right leg. Down the right leg, it's like a shooting, burning pain that's intermittent, but worse when ambulating. So 2 out of 10 at rest, 5 out of 10 when ambulating. So this indicates to us that there may be some neuropathic component as well to his pain, and that's something that we can address. He finds that the hydromorphone is effective for his pain relief as needed, and he's found that his activity level is reduced, but he's still able to go for short walks with his wife in the evening. He's eating and drinking well. He's normal body weight, and he's wondering if there is another option, because he does find that taking his doses twice a day he will sometimes forget that evening dose of his hydromorphone, and he's wondering if there is another option for him that maybe would be a bit more convenient. So we're wondering, is a fentanyl transdermal patch an option for him? Thinking about his case, he is experiencing stable pain. He isn't opiate naive. His minimum dose is greater than the 60 milligrams of oral morphine equivalent, and he's been on opiates for more than a week. He is normal weight. And we're looking at his medications, and he has no drug interactions to consider. So in this case, a fentanyl transdermal patch is an option that we could consider for him. What would be the initial patch dose? So in order to find this out, we need to look at his total daily dose. So he's taking the hydromorphone sustained release, 36 milligrams twice a day. So the sustained release regular dose is 72 milligrams in 24 hours. And he's taking 1 to 2 breakthrough doses every 24 hours. So now we can go to our order set and look at the chart on the back. We see that under the oral hydromorphone dose, 72 milligrams to 80 milligrams would lead us to start a 100 microgram fentanyl transdermal patch. So, fentanyl transdermal patch, 100 microgram per hour, apply topically and change every 72 hours. And now remember that you always have to provide a breakthrough dose whenever a patient is starting on a fentanyl transdermal patch, or whenever somebody's on a fentanyl transdermal patch. So again, we can use the order set. We can see that the hydromorphone, oral immediate release, he's on a 100 microgram patch. We go across, so 7 milligrams would be the breakthrough dose that we would consider for him. So in this case, our patient is already on hydromorphone 8 milligrams every hour as needed. He finds it effective. So we could go with 7 milligrams, but he already has the 8 milligrams on hand. So we probably just continue on that 8 milligram dose. Now we need to look at how we're going to switch from his current hydromorphone regimen to the fentanyl transdermal patch. So in this case, we would look at the switch schedule on the order set and apply the oral sustained release to the fentanyl transdermal patch schedule. So with him, we want to again write in specific times for when we would like him to apply the patch and then take his last sustained release dose. So we can time the patch to start whenever he would be normally taking his sustained release dose. This is the fentanyl transdermal patch order set, and this is how we could utilize it to order the medication for this fellow. So we can say yes, that the patient has chronic stable pain requiring around-the-clock opiate relief, that he has demonstrated opiate tolerance, and that this is a new start. And that's a really good communication tool for all those that are involved in his care and who will be involved in starting the fentanyl transdermal patch. Then section 2, we tick the fentanyl transdermal patch 100 microgram per hour. And then in section 3, we write in his breakthrough dose. So hydromorphone 8 milligrams every hour as needed for pain. And then we would sign this order set. Then for further direction, in the physician orders, we could write in the times. So we could say Monday at 9 a.m., we're going to apply the fentanyl transdermal patch and give the hydromorphone CR 36 milligrams PO once, then discontinue the hydromorphone. And also we want to specifically write to continue that breakthrough dose of hydromorphone IR 8 milligrams every hour as needed. And to recognize that more doses may be needed while the fentanyl patch is building up to steady state, so over the first 24 to 48 hours. So we follow up with AW, and after 24 hours, he's had the patch applied and he's needed 6 breakthrough doses of his hydromorphone 8 milligrams orally. His pain levels of 4 out of 10 at rest, but it goes up to 6 out of 10 with activity. He does find that the hydromorphone is effective at reducing his pain, so when he takes it, it goes back down to a 4 out of 10. So what do we do in this case? Keep in mind, again, this has only been 24 hours on the patch, and we would expect that he would need more of the breakthrough doses. So what we would do for now is just continue the fentanyl 100 microgram per hour patch. We would not think about changing that dose at all. And we'd continue to utilize the hydromorphone IR 8 milligrams until the fentanyl patch reaches steady state. So for at least 72 hours, this is going to be what we continue to do. We also want to keep in mind on those follow-ups to see if the patient's experiencing any side effects from the patch. He has been on opiates before. However, when you change opiates, the patient may experience some drowsiness, may notice that he's constipated or experiencing some nausea. So it's important to follow up with the patient and see if they are experiencing any of these side effects and that they're able to manage them. Now it's been 72 hours after initiating the fentanyl patch. He, in the last 24 hours, needed 3 hydromorphone IR 8 milligram doses. So in this case, again, maybe we'll ask him, is he experiencing any side effects? And he has said no, he's doing well. He has no drowsiness, no nausea, bowels are regular, he's still managing it with Senecot. He's had to adjust the Senecot dose, but he's still having regular bowel movements. This has been a first initiation of the fentanyl transdermal patch. There's a good chance, because we're just getting an estimated dose, that we will need to adjust the dose and possibly go up in dose for the fentanyl transdermal patch. So it's not unusual that we would do that after the first 3 days. So we'd assess for side effects, and then we would consider recalculating his dose based on the number of breakthrough doses that he's needed. So his current dose is the 100 microgram patch, and the breakthrough doses is hydromorphone IR 24 milligrams in the last 24 hours. And again, we just want to calculate based on the breakthrough dose in the last 24 hours. We could disregard day 1 and 2 when starting the patch because we would expect that he would need more breakthrough doses then. So we want to determine the equivalent dose of the hydromorphone IR to the fentanyl patch. So we've got the hydromorphone IR there, and he's needed between 12 and 26 milligrams of the patch, of the oral hydromorphone. So we could increase his patch by 25 micrograms. So his new dose is the fentanyl 100 plus the 25 to equal 125 micrograms per hour, applied topically, changed every 72 hours. And remember, we need to recalculate his breakthrough dose whenever we change the fentanyl patch strength. So looking at the 100 microgram per hour patch, it would be 7 milligrams of hydromorphone oral. For the 25 microgram, it's a 2 milligram hydromorphone. So we'd add that together and we'd have hydromorphone 9 milligrams orally every hour as needed. And then we'd fill out the order set again by ticking it off. So again, we could tick off that Yes, the patient has chronic stable pain. Yes, they demonstrate opioid tolerance. But now, instead of saying it's a new start, we tick off the increased dose box. So that indicates we understand that yes, the patient has been on the fentanyl patch, and we're making a conscious decision to increase the dose of the patch. Then, section 2, we tick off the fentanyl transdermal patch dose of 125 microgram per hour. And then section 3, we would include that hydromorphone immediate release 9 milligrams every hour as needed for breakthrough pain. And this is where on the order set, it does say remove all old patches prior to application of new patches and rotate site. So in summary, it is strongly encouraged that the fentanyl transdermal patch order set is utilized for all fentanyl transdermal orders. I hope that you find that it's a useful tool. It helps for clear communication, and as well it has the resources on the back in case that's needed for any dose increases or changes. The fentanyl transdermal patch is only indicated in certain situations, so keep in mind when a patient maybe has acute pain or it's unstable pain, and you expect that over the next period of time, the patient will be experiencing changes to their disease, progression, or other things that may cause some changes in their pain control. And if that's the case, perhaps a fentanyl transdermal patch is not the best option, and it would be better to go with a short acting opiate in the meantime until their pain is controlled and stable. Hopefully, you will utilize the tools on the order set, especially that equianalgesic conversion table, keeping in mind that it's unidirectional. This is also allowing for us to have a standardized table that's used throughout Northern Health, rather than having to go and look up another one just on the internet. You want to always adjust the breakthrough dose every time a new fentanyl patch dose is ordered, and do not titrate the patch too rapidly. So if a patient's already on a fentanyl transdermal patch and you increase the dose, you want to wait at least 6 days before you would increase the dose again. And if you find that you are quickly increasing the dose, and you're not seeing a lot of pain relief, that's perhaps a time when you should stop. Consider if this is the best option for pain control, and maybe consider if there's anything else going on that's causing the pain to not be controlled. Thank you very much for listening to this webinar. These are my references, and if you do have any questions, or you would like any help at all with the calculations for the patch, especially if you have a patient who's on a fentanyl patch and you would like to rotate them off, I would recommend that you calculate the dose of the new opiate longhand to make sure that you do have an approximate equivalent dose, and then you can adjust the dose from there. If you need any help with that at all, please feel free to contact the palliative care consultation team, or myself, the pharmacist. Thank you.